Hello, everyone. Welcome to Hedgehog After Hours. My name is Kyle Edward Williams, and I'm an editor at the Hedgehog Review, which is a journal of ideas and cultural analysis. And the Hedgehog Review is published by the Institute for Advanced Studies in Culture at the University of Virginia, which is an interdisciplinary research center and community that seeks to understand cultural change in the modern world. And tonight, I'm glad to be joined by my friend, Paul Nedelisky. Paul, how's it going?
It's going well, Kyle.
Good. Paul's a philosopher by training, and he is assistant director at the Institute, and he's going to introduce our guest.
Thanks, Kyle. Our guest is Paul Scherz, who is the Our Lady of Guadalupe Professor of Theology at the University of Notre Dame, and more importantly, a fellow of the Institute for Advanced Studies in Culture. And he is the author of a number of books. The book we're going to be discussing tonight is his most recent one, entitled The Ethics of Precision Medicine, The Problems of Prevention and Healthcare. Not too long before that, he published a book called Tomorrow's Troubles, Risk, Anxiety, and Prudence in an Age of Algorithmic Governance. And prior to that, co-authored a book with Joe Davis, The Evening of Life, Responding to the Challenges of Aging and Dying Well. And also another book, sole authored, Science and Christian Ethics with Cambridge in 2019. A brief word about how we're going to proceed. Kyle and I will ask Dr. Scherz a few questions. And then as you watch, if you have a question, feel free to use the ask question function on your Zoom interface to submit your question. And Kyle and I will see those questions and we'll relay them to Paul Scherz. To kick things off for us, I always think it's an interesting question. Where do books come from? Paul, what's the story of this book? Where did this book come from?
Great. Thanks. Thanks for having me here, and thanks to all the people coming tonight. So before I was an ethicist, I was a geneticist. I did genetics research, got a doctorate, did a postdoctorate, and so this book arose from my interest in how the field changed. So when I got into the field back in the late 90s, we were really trying to use genetics to find kind of causes of disease, genetic mutations that were causing disease. And then after the genome was sequenced, we found out that there were very few of these single monocausal genetic pathways, right? Very few single genes that cause diseases. And so the field was working on genomics for a while. And while I was still doing genetics, I started seeing people looking at, well, maybe we can use multiple genes to kind of understand something about disease or understanding something about disease risk. And then at the end of that point, after that, I left the field. And in the early in the last decade, I started to see things like 23andMe come out, and reading the genetics literature, I just saw that more and more things and more research was focused on risk. It had become much more of the broad kind of focus of the field. And you saw leaders in the field, like Francis Collins, who said that the goal of what this new genetics precision medicine would be was to find and determine health risks.
Hmm.
And so it was really interesting seeing this growth of risk and this focus on risk. And more disturbingly, as the decade went on, you started seeing more people trying to find not just the risk of disease, but the kind of risk and probability of different kinds of traits like low intelligence, height, various other kinds of things, raising somewhat specters of the early eugenics that we saw, and brought me great concern. Um, a second strand that led this. So I was interested in risk and genetics, and a second strand was just as I started to approach middle age, you start to go to the doctor and people are asking about the numbers of all kinds of things like weight, blood pressure, and all these kinds of topics. They want you to do screening tests. And as I looked more into each of these, it was like, oh, all of these are also about health risks, like genetics. And this is also feeding into this whole focus of precision medicine that's growing in the medical system. And I started to I wanted to ask myself the question, what does it mean to focus so much on risk? What does it mean to transform? And this is not just happening in medicine and healthcare and genetics, but across society. There's a huge focus on risk and risk reduction. And I was interested in what that meant from kind of an ethical perspective, but just and by that I mean this perspective of how do we live a flourishing life? And what are the anxieties that arise from just focusing on risk? And what do you miss if you're focusing too much on risk than other kinds of problems and really present dangers? And is this kind of focus on individualistic, probabilistic risk, is that the way that we should be handling these problems? And it's out of those kinds of questions that my previous book, Tomorrow's Troubles, and this book really emerged.
That's interesting. Connecting those dots, in some ways, it sounds like this project is a continuation or maybe zooming in on another specific instance of the way we're thinking about risk in a particular field, dovetailing or growing out of your prior book. Do you have a name, or is there a name for this broader, maybe social ethos that's centers on an obsession with risk? Do we have a label to put on that? An easy way to talk about it?
Yeah, I tend to think about it in terms, I mean, what Foucault, the name that he put on it, and he was really the one who focused on statistics and the role of statistics in society and probabilistic distributions. He talks about it in terms of biopolitics. Now, Giorgio Agamben has taken biopolitics in a different direction than Foucault did, but I think that is his work on how statistics is really a way through which modern power operates. And when you're thinking about risk, you're thinking about probabilities, you're thinking about statistics. So I just wanted to correct something that you said that this was a book that came out of my last book. But in fact, I always wanted to do a book on genetics, but then I realized I needed to really understand probability theory and how that plays into practical reason in society before I could do this more specifically medical book. So the first book was actually just kind of a precursor to this book.
It was your homework.
Exactly.
Interesting.
Yeah, on Paul Nedelisky's point, it's interesting how risk has shaped so much about how we understand so much of life. Of course, risk is a pervasive feature of the financialized economy, and gets into everything from managing hedge funds to managing insurance companies to managing any kind of business. It strikes me that managing through statistics works really well for certain kinds of activities, perhaps, but other activities are sort of stubbornly resistant to it, and there's all kinds of unintended consequences that come out as a result of it. Anyway, this book, I think, is a good example of what goes wrong when risk thinking sort of goes wild. But I think Paul Nedelisky had a question that he wanted to throw out there.
Well, I thought it might be helpful for our audience, Paul, if you could sort of broad stroke the general argument of the book.
Yeah, so the general argument is that we have transformed our vision of health. You go back 50 years, 60 years, 70 years, health was mainly about felt illness. And, I feel ill, go to the doctor, and they treat. It's really now, I think, much of how we talk about health is in terms of risks of disease, like the yearly appointment. A lot of what we're doing in medicine, a lot of even our medications are about reducing risk. And this works well in many cases. If there's this large risk and someone is at a major risk of high blood pressure or something like that, then yes, that totally makes sense. But the problem is that it's hard to restrain this kind of risk thinking. Like how much risk is too small to worry about. People get caught up on even like the smallest amount of risks and want to intervene. The dangers with that is that every time you intervene to reduce risks, it causes other kinds of risks, other kinds of problems arise. So all surgeries to kind of do, preventive mastectomies or something like that, if you had a genetic predisposition to breast cancer, for example, they have their own risks. Even screening tests have their own risks, like in doing biopsies and false positives, you have risks for these kinds of things. Medications that reduce risk, some of them have their own dangers. This is like a lot of the osteoporosis medications. They're supposed to prevent bones breaking, but some of them can also cause bones to weaken as well, and they have a side effect. So you have this increased focus and this increased danger, right? So, and that's just practical. I think there's also a societal danger in that in the individual, it raises the level of anxiety. You start to think of yourself as a person at risk. Um, and you start to also, especially when you get into genetics, think about your offspring as a potential risk. And you want to, it leads to desires for control that we saw in earlier eugenic times to kind of control what the risks facing your offspring are through genetics. It also, institutions want to control risks as insurance companies and health systems, they want to kind of make money and reduce their exposure by managing their health staff more intensively. And that's a lot of what we're seeing in the medical system, that staff are under increased pressure to prescribe on certain guidelines or follow certain protocols. And sometimes this occurs even against their best judgment. They're just kind of forced by the staff because all of these things are on probabilistic population level distributions. So a risk is only for a population. It might not fit an individual circumstance very well. So when you try to manage these things at the level of the population, you frequently end up making mistakes because maybe that person isn't actually at as much danger when you know them at an individual level. So, I mean, that's a lot of the kind of dangers that I'm exploring. And at the end of the book, I kind of how do I talk about how to address the problems that risk thinking is trying to address.
When you described some of the potential shortcomings of this, risk-based approach, and one of them was we don't always know there's sort of unforeseen consequences to thinking too much about risk or the things you might prescribe to populations in an attempt to mitigate one risk. These strike me as the kinds of thoughts and concerns that the people who are thinking about health from a risk perspective might have, or is it that they've overlooked these? And this is part of the point you're making in the book. On the other hand, I was wondering, could it be the case that sort of the deeper cause or driver of this approach is not really and fundamentally about the health of human beings, but it's something else? Is it a consequence of the bureaucratization of medicine, so that you need sort of indices and metrics for thinking about success? I don't know. Could you expand more on what is really driving? I'm sure there's not just one thing, but what are the main kind of causal drivers of this approach?
Yeah, so I think in response to that, I think there's two things. I mean, one, our medical care is so kind of fragmented and everyone has their own specialty and is focused on their own risk, right? And they want to get, the people who are doing, colon cancer, want to get the colon cancer level as low as possible. There is no acceptable level of risk for that. And there's no acceptable level of risk for kind of cholesterol levels. And they're just focused on that one risk and reducing it. But in a lot of our like screening, like the clinical trials for screening tests, they don't actually look at overall mortality as an outcome. They just look at mortality for the specific disease, for specific disease
Oh,
tested. So they don't look at necessarily the kind of other more causes of death. And most of our screening tests and a lot of our treating actually don't reduce overall mortality. They just do it for a specific thing.
so this is kind of a consequence of over specialization and a failure, kind of a lack of holism in terms of the overall approach to health.
Yes. Yeah. Not treating people as whole persons, and not just, thinking about their anxiety along with all the different bodily systems and things that can go wrong. So yeah, that is one of the major problems. But I think it's also about bureaucratization. So a lot of this risk reduction came along with focus on quality in medicine. And part of the idea is, so back in the 1990s, if you remember, there was, if you were, kind of people who remember that time, they were all trying to bring down medical care, and HMOs were trying to do that, but by restricting treatments. And that caused a whole lot of pushback. People did not want, I mean, we see today, people are still, get very angry about restricting treatments. Um, So that ceased to be a mode of regulating medical care. But our medical bills kept going up. And so when Obamacare was passed, they had this idea that the way that we can bring down medical cost is by reducing this future disease. So it became a kind of potential cost savings. Now, this was somewhat ridiculous because most health economists would say, well, you have to treat way more people to reduce risk, and people are
Huh.
going to be living longer and having more illnesses. So it's very low chance that it will actually reduce risk. But that was how it was sold, is that by having this kind of higher quality risk reducing treatments, you can bring down healthcare costs.
Interesting. Okay. We have a question from Ron Dworkin, and Ron asks, asks for the role of AI. He mentions that you in another essay, Paul, talk about the role of AI in making certain kinds of risk assessments. But he also wonders if using AI and thinking about AI as a risk assessment tool might further embed the obsession with risk. Can you elaborate a bit more on the role of AI in this
Yeah, no,
phenomenon?
AI is deeply embedded in the whole system of precision medicine. So healthcare systems have been buying up tons of medical records, and like tech companies are getting in, buying up lots of medical records. And the goal of precision medicine is to bring all the risks that AI can analyze in your medical records, with all the risks they can find in your genome, and they're going to give this total picture of risk. And the only way you can do that kind of large scale number crunching and holistic analysis is with AI. And the next step is, once you identify those risks, is to put it into the exam room and have the computer telling the doctor, and you already see this in some health systems where the computer will tell the doctor what kind of risks at that moment the patient might face, and then also suggest to them what kind of treatments they should provide for those risks. Right. So this is going to be a much more directive kind of approach to the doctor. And a lot of healthcare systems see this as, one of the benefits of AI is going to be able to tell you way more risks and, kind of expand that.
Sounds like fun.
Yeah.
I had a question that I wanted to raise about, well, getting to this question of data, where the data is
Mhm.
coming from and what it's built around. It seems like one of the big problems in your book has to do with this issue of scale, right? That risk-based medicine is based upon these studies of large groups, large segments of the population, and yet there's and yet we're individuals. Not any one of us perfectly represents group A or group B, and certainly not the entirety of the population. And so this sense, there's the scale is off, right? The prescription or the intervention that might work in as it applies to this large group doesn't necessarily really work when it applies to the individual. I could see someone responding to this and saying, "Well, yeah, I think Paul Scherz is onto something," but his argument just goes way too deep. The problem here is we just don't have enough data. We just need more information, more individualized information, in order to sort of let the individual scale meet the large scale, and then this can all actually work out really well. What would you say to a skeptic like that?
Yeah, I mean, it's impossible to talk about like an individual with population in that way. I mean, there is a reason it used to be called, if you go back 8 years or so, personalized medicine. That was what this field was called. They had to change that name because they realized, oh, we can never get to the person. We're always going to be stratifying populations. Right. So fundamentally, so that's why they went to precision medicine, because it sounds better than stratified population medicine. Um, so I think it is impossible to get that one person in that way. You're always dealing with populations. I think a second bigger problem is that even if you want to have it focused on a more specific population, you have to figure out who, what population that person would best belong to. I mean, this is a big problem with a lot of these genetic risk studies now, is that all of our data is from kind of people of European descent, generally kind of middle-aged people of European descent in America. They're doing better with that now, and they're doing more outreach. So, but there's still a lot of people who aren't even anywhere near that data. And even if they do start to break it out, and in some of these studies, they've tried to show like, here is a risk score for just African American people, or here is a risk score for just Hispanic American. You still have to figure out, okay, which group does the individual belong to? Because things like race are not a biological category,
Right.
right? So nobody naturally fits into these categories. And some people, since a lot of these are very cultural, right? There's this great study this great anthropology study of this. They were trying to use these more nuanced risk markers for the study of breast cancer and who gets mammograms. And they had this one woman who just was unsure of where to put herself because she always thought of herself as Hispanic, but she had moved from Spain to Mexico. She was unclear if that made her Hispanic or not, and which
Mhm.
place she would belong to, because these aren't natural kinds.
Interesting. We have a somewhat cynical question from the audience, but it's one that I kept thinking about as I was reading your book, Paul. And it's about, to what extent is this risk-based approach and the management of risk approach in medicine motivated by corporations who are driven by a financial bottom line? I mean, I think about, like, so many people that I know now have, Fitbits that monitor all kinds of biometrics. And I always have this, I don't know anything about medicine, so I have this nagging doubt. Is this really even potentially that helpful, or is this just a way to sell them another widget, another gadget? What's your take on that aspect of this phenomenon?
I think yes. I think there are people out there who see this as just a way to make more money. This is the bottom line. So, Norton Hadler is a doctor who was at UNC who gave me some advice on the book because he's thought about a lot of these things. And yeah, but talking to him about these things, he was always telling me what corporation the person that I was referencing their research, what corporation he was connected to and how he was making money off of his recommendation and things like that. So I think there is some cynicism there. But I also think this is coming out of like health systems who genuinely believe this will help reduce their costs and improve their outcomes. And there are a lot of people who are trying to. So one of the problems with AI is there's bias in outcomes and who gets recommended procedures. And a lot of these people are really committed to, kind of reducing bias, even if they don't recognize that sometimes having more people get a procedure isn't going to bring more health to people. So yes, I think it's both. Yeah, it's both and.
Kind of carrying on from that last thing you said, we have a question for Martha Bayless about what is the actual evidence that this risk-based approach leads to better health outcomes than the old way of individual diagnosis by a skilled physician?
Yeah, I mean, I think the best evidence that I always turn back to is like the kind of widespread data that shows that getting a yearly health checkup doesn't improve your mortality, doesn't improve
That's
mortality.
that's astounding to me. I mean, that's just
Yeah.
amazing.
Yes, I mean, it seems like, yeah, I mean, I think there's definitely, like, if you look at individual diseases, then you could probably find some place, but most of the screening does not reduce overall mortality. So,
Hmm.
and part of that is medicine has gotten really good at treating disease and helping people to live a long time, even after they've had things like heart attacks or cancers.
Interesting.
We have oh, Paul, did you want to follow up on that?
Oh no, I find that personally comforting, given that it's been about 5 years since my last checkup. But go ahead, Kyle.
Yeah, yeah, I'm with you there. So we had a question here from Charles Lowry, who's a consistent Hedgehog reader, and we're glad to have him ask a question that gets at a really important question that you raise in your Hedgehog Review essay, which he says one of the points in your discussion involved the alarming impact of statistical prediction on the autonomy and independence of healthcare providers, quote unquote, on the front lines. And Charles asks, is that an imminent or a longer term concern? Is
That Yeah, that's something
yeah.
that's already here. Already, health insurance, Medicaid, and other kinds of health insurers will reimburse based on quality metrics. So, if a certain percentage of your patients go and get on a statin at a certain level of, say, cholesterol, um, then you'll be paid at the full amount, but if you have lower levels, then you'll get paid a less amount, right? And a lot of these metrics that they're doing are on not because it's really hard to equalize these across populations. They're not metrics about um, who, right? They're not metrics about like who's dying, or who's living longer and things like that. They are these kinds of process metrics of who is getting treated or not. So these are already in place. What a lot of the AI is doing is it adds greater surveillance mechanisms for, kind of knowing who's meeting their kind of these quality metrics. And it also, the likelihood is going to be expanded because you're going to have the AI in the room that can play a directive role. So,
That makes it sound like the sort of purpose of the system, the purpose of care is to get people to accept further interventions. Like if that's what people are getting paid for, then it makes it sound like that's what the purpose of the healthcare system is, to have people more fully enmeshed in healthcare, the healthcare system. That strikes me as sort of tautological.
yes, it's to increase yeah, I mean, I think right now we have a healthcare system whose goal is to increase the level of treatment. Because, I mean, if you think about like you're at risk. People get at risk. You grow older, you get all kinds of risks. The risk of death is 100% for humans, right? So like, and as you get older, there's going to be more and more risks that come along. And that's just kind of how aging goes. So it is there's always going to be something else you can treat.
Mm-hmm.
We have a question from David Kaufman who says, could you comment on the fallibility of the data sets that are used to formulate guidelines for prevention or treatment, which then results in out-of-date protocols becoming embedded in practice, paradoxically raising risk? Sounds like he's thought about this some.
Yeah.
He says he's thinking specifically of sepsis protocols, and I don't know what the implications are there, but thoughts on this question, Paul?
Yes, I don't know the data about the sepsis protocols, right? Yeah, no, but I know that have been major problems. I'm just thinking about the mammography research. People have gone back and look at like the earlier kind of trials upon which things were based, and it looks like there's problems in the statistics of that they couldn't have gotten them naturally.
Huh.
Um, and we don't run enough clinical trials at large enough scales to see better outcomes. They're doing it more in Europe. You're getting some better kinds of tests of screening protocols. But those, but, but yeah, and those generally don't see that much of a benefit. Um, the other problem is that as time goes on, our treatment protocols get better, right? Our ways of treating heart attacks are much better now. Our
Hmm.
ways of treating cancer are much better now. So you have a much better chance of long-term survival right now than you did like 20 years ago. So if you're dealing with risk from data that's 30 years ago,
Hmm.
uh, it's going to totally change. I mean, the evidence is now out of date because it's going to look different how many people who actually had a heart attack, how long they survive versus
Huh.
control.
We got a good question here from our friend Catherine Moon. She says, "How do you see this risk ethos impacting the spheres of mental health and education?"
Yeah, I mean, I think in and of itself, it raises anxiety, right? I mean, you see
Hmm.
people who, get their 23andMe and say that they're their risk of kind of, Alzheimer's, and it
Yeah.
makes them anxious, right? Because there's nothing they can do about it. But even it raises anxiety, like if you just waiting on the results of a screening test, or if you need a biopsy, waiting on the results of a biopsy, right? So you have anxiety and problems arising like in that way. I think in terms of education, a nation at risk, right? Wasn't that the title of the old educational kind of um, report back in the day?
Oh yeah,
Yeah, I
yeah.
mean, it's thinking about students as risk factors. And, I mean, there's lots of violence and lots of things that happen in school that are bad, but there is also a lot of overreaction where people become medicalized, um, put into interventions far too early because they are seen as at risk for some kind of behavior or some kind of predictive kind of test.
Hmm.
So I think it is shaping education. In major ways, how teachers are interacting with students, how parents are thinking of their children, right? Right now, there are a lot of people who will get these kinds of genetic tests, see that they're at risks, and then will turn to kind of various artificial reproductive technologies, which will then allow them to select genetically the best offspring, right? So that's a real major transformation of between
Yeah.
generation and the next.
Yeah. How would you talk to somebody who is sort of the grip of this risk paradigm, and they think that using those kind of reproductive technologies, or let's just maybe we could think of any number of other kinds of interventions just for their own self. What would you say to that person? How would you sort of challenge the assumption that the most responsible thing to do is to embrace the most interventions possible? Because it does seem like comes down to this sort of question about what does it mean to be a responsible and successful human being. It seems to engage in risky behaviors is irresponsible. You see what I'm driving at?
Yeah, no, I do see what you're driving at, right? So, I mean, so in some ways, this is, putting on my theologian hat and then taking off my theologian. So I'd answer different ways depending on if I mean, in my theologian hat, I would say, the basic directive of one of the basic directives in the Sermon on the Mount is not to fear about tomorrow, right? That's not, you just shouldn't be that concerned, right? You shouldn't like take steps and work and prepare and things like that. But the overwhelming anxiety and thought that you're going to control the future just runs against a lot of monotheistic religions' belief and trust in God's providence and care. But I think you can take that in a stoic direction, that if you think you can control the future, you're fooling yourself, right? You can take some precautions, and I'm not, saying be totally irresponsible, take no precautions, or if you've got like some kind of serious pain, don't go to the doctor. But if you attempt to gain this control, it's ultimately going to be self-defeating, and it's going to eventually cause side effects, take over your life with trying to kind of just prevent all bad things from happening. I think there's also, what do we think about responsibility? Hans Jonas and a lot of other kind of Christian thinkers have talked about responsibility in terms of response. Right. Yeah. I mean, this is more, a lot of the Christian thinkers are thinking about responsibility in terms of response, in terms of kind of openness to the world and care for others. And I think especially when it comes to children, um, you have to respond to the child you're given in certain ways rather than try to shape them into some sort of ideal, which is never going to be succeeding.
We have a question, another question asking, or it begins with a statement. The reason people live longer after heart attacks is because of secondary risk prevention.
Mm-hmm.
We give medications to reduce the risk of subsequent events. It sounds like you support this kind of risk prevention, but not other types. What's the qualitative difference between addressing risk for a patient with high cholesterol compared to a patient with a history of heart attack, for instance?
Yeah, I think there's a major difference because my concern is when we medicalize life as a whole, when we try to convince everyone to just think of themselves as someone who's at danger at all times, right?
Hmm.
When we think of ourselves as people who are at risk, I think that's very existentially destabilizing, right, for
Mhm.
our lives and will lead in problematic directions. Now, on the other hand, if you already had a heart attack, you know that's a problem, right? So going to continuing on, I feel that's a kind of further treatment of a problem you've already had. I mean, I think if even if we think about genetics, if you have a family history of this kind of disease in your family, um, that's already existentially destabilizing, right?
Mhm.
And so I'm not against, you know, any kind of risk reduction. I'm not even against testing people for risk and only treating the very high risk. I think it makes sense if someone has like, they're in the very edge of the bell curve on like high risk. Yes, it does make sense to do prevention. My concern is how do we keep that from just expanding into the entire population to kind of and letting risk kind of, take over our entire lives.
You're pushing back against a certain kind of like monomania in a way.
Yes. Yeah, and I think the monomania has really kind of, yeah, captured us.
I wonder if you could talk a little bit more about some of your positive proposals at the end. I'm especially thinking I liked your anecdote about I think it was called Laguna Honda, this unusual hospital in the San Francisco area, and I actually went online and read about it a bit. Um, if convenient, maybe tie that example into your description of your positive proposals because I found it kind of an interesting story.
Yeah, so I mean, I had a couple of so my positive proposals are first, a lot of our risks. So, and the second thing that I should have answered, the last one is you're focused a lot on kind of what I talk about in this book is this individualized risk reduction. A lot of our disease risk comes from larger social determinants like poverty, like bad working conditions. These
Hmm.
have a lot to do with who has heart attacks. So I think there's a lot of structural changes that can be introduced. Like, we can even structurally change our physical environment to allow for more exercise. And that's good in and of itself because exercise makes people feel better. And reducing poverty is good in and of itself because, you don't have that kind of exploitation. So that is what I think is the first step to do, is to reduce these kinds of structural factors causing disease. Now, the thing is, that's not something that medicine can do. And a lot of problems is medicine right now tries to get into population health and starts to think, oh, maybe we can fix the neighborhood. And I don't think health systems are going to be very good at fixing those social conditions. The other thing that I think we should think about doing, I mean, I think in one's personal life, there's a lot of writing in in kind of medicine over the ages, and even a lot of current medicine about developing a good strategy of life that is regimen of life that's fairly healthy, right? There's a lot about, so a lot of this book is framed in terms of the virtues. So part of the virtue of temperance is eating a reasonable amount, sleeping a reasonable amount, taking care of yourself in kind of a reasonable way. So developing those personal habits is important. And I wouldn't, kind of suggest people don't do that. For many, it's impossible, be it for one reason or the other, because of pressure of time or things like that. But that's something to encourage. And the other thing is that we haven't talked about is one of the real dangers I see in the risk kind of framework is what happens to the people whose risks can't be reduced. People with severe disabilities or people in life circumstances that you just can't bring those risks under control. In our current kind of system, they are left behind in a certain way, just kind
Hmm.
of abandoned by the medical system, or in more problematic ways, a lot of this genetic work is to make sure that these kinds of people aren't even born, right? In this kind of modern day liberal eugenics. Um, but I think we do need to re-embrace spaces in which care for people who otherwise can't be cared for can be continued, right? A lot of in modern bureaucratic systems, they're trying to make things so efficient that they don't allow people to be kept in hospitals, right? They need to get everyone out the door and on their way. And this wasn't the way things always were. There used to be many more institutions, hospices, hospitals that were set aside that allowed people for long-term care, long-term stays. And this is the picture that Victoria Sweet paints in God's Hotel, which is of this Laguna Honda in San Francisco, which is this place that's kind of the care place of last resort, where the hospitals would send people who they couldn't heal, they couldn't send home, who needed longer term recuperation. And she just talks about the beauty of the medicine, of how there wasn't really much they could do for a lot of people, but they could listen, they could figure some things out, and being with them for a long time helped them. And for a lot of people, what they really needed was time to allow their bodies to heal and to kind of become a stable category, a kind of stable lifestyle. And I think we need to allow more spaces like that, in which more spaces of care, which most of these we've closed down or we're closing down. Leave those spaces open for us.
Interesting. We have a go ahead, Kyle.
Excuse me. I was thinking about. I thought in one of your final chapters where you are getting into well, you talk about the sort of pseudo solidarity of public health, and I found that to be very interesting and incredibly incisive. That there's a sort of veneer of solidarity when it comes to public health, but you write that it is a solidarity with statistical others in a population. The common good is embodied in the statistical metrics of the population, which, as you just said a moment ago, suggests that that really what you're in solidarity with is those whose outcomes can be improved, whose risks can be mitigated, and those who fall outside that are basically written off as kind of problems, right?
Yeah, no, I mean, this is a lot of what this efficiency, like risk reduction, and a lot of times is also tied in utilitarian kind of frameworks of, optimizing care. Right. And that is very clearly, they say, this is about people who are not necessarily, it's not about the person in front of you. It's about this kind of potential other, the statistical other. And that's who you're caring for, is this kind of imagined person in the population. And frequently that leaves the person right in front of you with their real pain kind of outside of your kind of field of vision.
Mm-hmm.
We have a couple of questions from Christopher Cronkite. His first question is basically about, to what extent are your critiques sort of a product of the immature or nascent state of this field? And he's suggesting that, he says, newer data sets, while still not perfect or complete, have shown there's incremental improvement in risk assessments for disease states. One that comes to mind is genetic risk scoring for prostate cancer stratification for symptomatic prostatic hyperplasia, which have improved beyond AJCC risk scoring. I don't know what that means.
I don't know what he's talking about.
But he's basically saying, where he concludes, are some of these arguments against precision medicine a byproduct of its still maturing state? And it seems clear some of your critiques are not about that. The anxiety aspect, for instance, would not be improved theoretically, even if the risk assessment was being really good on the health front. But are some of your criticisms, do you think, an artifact of this sort of the early state of the field?
Yeah, I mean, certainly these things can be improved, and that would help on a level. But I don't think it's only about that. I mean, I think on the other hand, even with the risk assessments being better, you have to have better clinical trials of the interventions to remove the risk. And I think that is not what we're having. And I think we need to have a much more honesty about, how these interventions are actually overall improving health. So it's not just the risk assessment, but it's also the intervention side of things. And I think more broadly, I would say I'm not totally against risk assessment. As I said, like if someone is at really high risk, right? They have the BRCA1 gene and a familial history of breast cancer. Then, yeah, of course, it makes sense to think about risk, doing something and stepping in and engaging. And if you could always keep it at that, we're going to think about the top 5, top 10% of people at risk. But that's not what we've seen in the history of these kinds of risk scores. You always see what the boundary of the risk that should be treated. You always see that coming down because it's so impossible at a political level to say, well, that's enough risk to deal with. We should allow, whatever happens beyond that risk score is fine. You see this even in a lot of activist writing where they're like, why didn't the test catch me, right? So a cancer activist. And these tests don't catch everyone. That's just what happens. And eventually we have to accept that so that we don't have just massive amounts of false positives.
Christopher asked another question. He's wondering, on the anxieties front, to what extent is this perhaps strengthened by what he sees as more of a modern expectation of constant health, where his thought seems to be that perhaps previously people accepted that their life was going to be full of physical suffering. And so, this expectation that you would be able to be constantly healthy wouldn't be there, would have helped mitigate anxiety about potentially not being healthy. What are your thoughts on that kind of change in the timeline perspective?
Yeah, no, I mean, I think acceptance of kind of minor, even moderate levels of pain and discomfort is something that has gone away in some ways, and in much of kind of modern kind of upper middle class society and various kinds of suggestions, various kinds of areas. And I think there is a way in which, just as we age or at any stage of life, that we need to accept that sometimes we're just going to be uncomfortable, that we're going to have back pain, right, for a little bit,
Yeah.
that might go away, right? Yeah, I talked about Norton Hadler before, and a lot of his work is on back pain, and he just talks about how often, you know, everybody within a 6 months, if you give it a certain, I forget exactly the number of years, but a certain number of years will have some sort of back pain. And for the most part, that will go away over time. You might need to do some exercises or something like that. The problem is, like, we frequently jump in to intervene, and these interventions can cause problems even before that's an issue. So yes, I mean, I think it is tied to the fact that we think that we're never going to have these kinds of aches and pains. But I think there's a broader thing about these future dangers that is different than just that kind of not wanting to have discomfort. It's the future dangers that we fear, even though we have no experience of them yet, that I think is bringing about a lot of these problems. And I think that's something new.
We also have a question. How would your conclusions about risk impact or relate to decision-making in palliative care, especially the administering of painkillers at the end of life, in situations where painkillers may hasten life's end?
Yeah, I mean, this is so at that point, the person is already dying, right? At that point, and so basically what medicine can do at that point is relieve discomfort. So if it hastens death, again, this is coming from a theological perspective. Like, death is not the worst thing in the world. I mean, kind of sin, death as sin is the worst thing in the world, but death is not kind of the thing that we should get rid of altogether.
It's appointed unto man wants to die.
What?
It's appointed unto man wants to die.
Yeah, yeah. Right. Yeah, no, I mean, it is something that we are going to happen to us as humans. So at a certain point, when you can't extend life without a burdensome treatment, then it becomes a point of the goal of what the healthcare team is trying to relieve the pain. And then it doesn't matter as long as you're following proper protocols, right? There's a difference between intentionally killing someone and hastening death.
Martha has another interesting question here about, she says that she observes that in the Boston area, the waiting times for nearly every screening and tests are getting longer and longer. I think that's probably not just in the Boston area.
Yeah.
Is that related to the increase in ordering tests on grounds of relatively minor risks? Is there a traffic jam of tests?
I haven't heard about that. So I can't say yeah. I mean, I can't um distinctively give a reason for that because I'm unfamiliar with that introduction of those kinds of delays. But I would not be surprised. The more people that are kind of taking up those slots, you would
Mm-hmm.
think that it would slow down. Although testing is one of those growth areas in healthcare, so I'm surprised that there aren't more testing businesses opening to take care of that.
Huh. I have a very sort of individual practical question. Um, say I read your book and I'm totally persuaded. I guess one of my questions is within the decisions that I will make in my life, where do I have a say? Where do I make decisions that would affect whether I'm going to take the task of like maximal risk mitigation or to step back in the way that you're suggesting in certain places? Is it in these checkup meetings? Will doctors say, "Well, we'd like to screen for this," and I guess I'm wondering what does it look like to be presented with the possibility of maximal risk prevention, and in that moment, um, is the thing to do say, I'm comfortable not doing that. Let's just pass on it. What's kind of your very practical advice for the individual who's going to
The
be
conscientious objector.
the conscientious objector? Yeah.
Yeah, I mean, well, first, don't send your DNA off to be screened. That would be the first thing. Yeah, no, I mean, it is in that physician's office, right?
Yeah.
In your yearly appointment, they ask you to do a lot of stuff, and you have to give your autonomous approval to all of those procedures, right? And if
Hmm.
you don't want to do that, then you don't have to do that. I think. I would prefer not to go that direction though, in that just sets up a kind of adversarial relationship between you and your physician. I mean, the thing that I've always found best is to find a physician who has a kind of similar sense of risk as I do. And there's a lot of them out there who are not maximalists in this kind of treatment or testing and will like explain, well, here's the benefits, here's the drawbacks to this kind of test, and will help you think through those things. So that's the ideal is you find a good physician who kind of can talk with you about these
Who you won't
things.
be constantly debating with, despite not knowing as much about medicine. That's good. That's good advice. I
I think
remember.
doctors love that.
Yeah, yeah. Well, but what you're recommending is what I lucked into with my physician because I remember I had to go to China and at the CDC or someone recommended 20 vaccinations. And she looked at the list and said, "No, you don't need this. You don't need this. This doesn't
Right.
exist anymore." And she got it down to 3. And I was like, I'll be sticking with you for a while.
Yeah, no, and that's the thing. It's these people who are, I mean, a lot of times it's harder to find them because it's a lot of times the people in independent practice or kind of at various different places where they have the freedom to do that. Because that is the kind of concern with the bureaucratic control is that people won't have that freedom.
Kyle, any thoughts about what we should ask for the last question? We're closing 2 minutes.
Yeah, I don't know if I have a question, but maybe if I talk for 30 seconds, I can come up with one. But I was struck by the sort of paradox involved in trying to construct a system that I think most people want it to produce good health outcomes, right? It's ostensibly for health and wholeness. But as you take more, if you examine a person's body, right, as you observe in the book, you find that everyone's at risk for something. Everyone's always pre-something. And the body, through that process, comes to be disclosed or rendered as a more and more of a problem.
Mm-hmm.
Well, because the body's always breaking down, the body's going to die. And so then you're sort of pedagogically led to think more of all the various ways in which the body is failing, and you come to think of it in a much more instrumentalist sort of way. And that's just it's an odd paradoxical outcome. And it strikes me that at the core of this story is a sort of anthropological question about what is the human body for, and how do we understand its limits?
Yeah. No, I mean, this is at the end. Yeah, in the first chapter, I described this as somewhat of a Gnostic kind of approach to the body, that it always is suspicious of the body, that it creates in yourself this distrust of the body. And it's something that can never be escaped because you solve one risk and other risks will emerge. And many people have talked about modern medicine in its worst cases can create a Gnostic approach to the body, right? Just kind of this control or like wanting to upload your mind away from the body. But this is this suspicion of the body and kind of,
Yeah.
yeah.
There's it's it has a sort of elective affinity to a certain kind of transhumanism. But that would get us into another discussion. So and we're at
That's
time,
the next
so I think
book.
That's the next one. We should probably end it here. And I just want to say thank you, Paul Scherz, for coming to talk with us about your new book. It's called The Ethics of Precision Medicine: The Problems of Prevention in Healthcare, and it's out this fall from Notre Dame Press. So go look that up. He also has an essay in the latest issue of the Hedgehog Review, the fall issue, which is called The Pathologies of Precision Medicine. And it's up on hedgehogreview.com now, out from the paywall, so you can go read it. And so be on the lookout for that, and be on the lookout for more Hedgehog After Hours discussions in the new year. You can stay in the loop by going to hedgehogreview.com and subscribing to our newsletter while you're here about recent publications and upcoming events. And while you're there, please be sure to subscribe. So thank you all for being here. Thank you, Paul Scherz, Paul Nedelisky.
Thanks, Kyle.
Thank you. This has been great. Really
Have a good evening.
appreciate it.
Good talk.